Well, good afternoon. I am Judy Hung, President-elect of the ASE and an echocardiographer from Mass General Hospital. I'd like to welcome you to this ASE webinar reviewing the ASE statement on the reintroduction of echo services during the COVID-19 pandemic. This statement was published on the ASE website on May 18th and can be downloaded to provide a guide on how to reintroduce echo services in a safe and practical manner as we live through this COVID pandemic. Next slide. This webinar today will feature a panel of Echo Lab directors and ASE leaders who will provide a brief overview of this statement, but more importantly, be available in a forum to address questions from ASE members and others regarding this very important process. We will show some of the questions we have received, but also feel free to ask questions live during the webinar using the chat function. I would like to now introduce my fellow panelists, Dr. Madhav Swaminathan, ASE President, Dr. Meryl Cohen from the Children's Hospital of Philadelphia, Dr. Michael Main from St. Luke's Mid-America Heart Institute in Kansas City, Missouri, and Dr. Carol Mitchell from the University of Wisconsin School of Medicine, Madison, Wisconsin. Next slide, please. I would also like to thank our sponsor, Bracco, for sponsoring this webinar. Next slide. This is the agenda for this webinar. First, an overview of the statement and prioritization strategies for scheduling echoes. Next, a consideration of operational issues, sonographer perspective, and then pediatric perspectives. And then the bulk of the time will be addressing questions submitted to the panel. Next slide. So I will start with an overview. The development of this statement was based on the recognition that there will need to be new processes in place for performing echoes during COVID-19, specifically addressing operational issues such as when to reopen, how to prioritize the scheduling or rescheduling of echoes, as many of these were deferred during acute surges of patients with COVID, testing, and PPE considerations. The statement also discussed special considerations for transesophageal echo, stress echo, and pediatric population. Next slide. I'd like to briefly review Table 2, which proposes a scheme for how to prioritize the rescheduling of echoes based on priority tiers. We define the basis for each priority rating and then provide examples of each. For example, in this slide, priority tier 1 is high priority, and these are patients with either active symptoms attributable to cardiovascular disease or for safety monitoring during treatment, such as for chemotherapy. Next slide. For tier 2, considered medium priority, the basis for this are asymptomatic patients, but who have chronic cardiac conditions that require monitoring. An example of this would be patients with severe cardiomyopathy or severe valve disease. Next slide, please. Tier 3 is considered low priority, and the basis for this is routine follow-up for chronic disease such as hypertension, coronary disease, or stable or mild valve disease. Next slide. I will now turn this over to Dr. Swaminathan, who will provide an overview of operational considerations.
Thank you very much, Judy, and I'm happy to provide these considerations that we had discussed and formulated as a group. Important in this operational workflow consideration is everything that we're doing to schedule patients, some environmental considerations, some operational considerations, how we're going to schedule these echoes. Dr. Hung talked about creating priority tiers, which is essentially the first step as to who we are going to image. And then, of course, there are some scheduling workflow considerations you contact patients, digital communication being preferred. How do you screen patients and when do you screen them? And at one time or multiple times, and we suggested that this be done at multiple times in terms of questionnaires prior to considering testing of symptomatic patients. And then there's how many people are allowed in your clinic or in the work area, limiting patient escorts or visitors to only those essential or required. And then there's the spacing between exams to allow for sanitation protocols. And also that changes the number of patients that are being done in one particular day, or the staffing considerations, all that changes because you have to allow for extra time. And then there are environmental considerations such as disinfection of bathroom facilities and examination rooms, designating special areas for examining COVID positive or COVID suspect patients, airborne isolation rooms, for example. Next slide, please. And then there are issues with waiting areas and how do you communicate with patients to make sure that there are a minimum number of people in that waiting area or interacting with staff, for example. How do you ensure appropriate social distancing between patients and reception staff, for example, creating plexiglass barriers and between patients themselves, making sure that there's disinfection material readily available and face masks are available for patients or escorts and for all staff members. And then there are staffing considerations, some of which include COVID-19 screening of staff, adequate staffing for covering backlog of cases. Now that we are resuming operations, we expect in some areas that there will be an increase in number of cases and sort of a catching up on the backlog. And so how do we staff those extended work hours or weekends? And also strategies to cope with stress and enhance resilience during these periods of increased workload are really important for labs to consider. And then monitoring PPE supplies to ensure uninterrupted operations, assuring social distancing and sanitation in reading rooms especially, and in break areas and staff lounges, again, focused on limiting the possibility of transmission of disease. Next slide, please. Turn it over to Carol Mitchell for a sonographer's perspective.
Okay, next slide, please. And I'm going to start out just talking about and sharing with you what we are doing at our institution currently for personal protection equipment for sonographers, how we're handling the schedule, room cleaning, and the patient screening and entry into the echocardiography laboratory procedures that we're employing currently. So at our institution, sonographers wear masks, face shields, and gloves for transthoracic and stress echoes. For transesophageal echocardiograms, sonographers also wear masks, face shields, and gloves. And if it is a COVID positive patient, then the TEE exam is performed in a negative pressure room. An N95 respirator is worn along with a face shield, gowns, and gloves. For the schedule, we actually are currently back to our normal procedure times with no COVID blocks. We are also opening up our labs at the hospital, and this seems to be a very attractive option for some patients who are more comfortable going somewhere where there isn't a known COVID patient hospitalized. As far as rooms, there's kind of a new standard for cleaning now. Everything is wiped down that used to be, so the EKG leads and surfaces of the ultrasound system, the patient bed. But in addition to that, we're also wiping down all hard surfaces in the room, and particularly anything that a patient's clothing might have come in contact with. So like your hangers for clothes, door handles and knobs, other countertops, the hard surfaces. And then those are all wiped down with wipes that are approved by our institution and the manufacturer for the ultrasound systems that are appropriate. And we're monitoring and making sure that we adhere to the appropriate wet times for those. As far as patient screening and entry into the echocardiography laboratory, at this time, patients are screened by telephone when they make an appointment. And then when they enter the facility where the echo is to be performed, they stop at a screening station where again, they're screened by an individual for symptoms and their temperature is taken. And then they're also giving a mask to wear to travel further on into the institution then. And that's our overview of what we're addressing those 4 bullet points with right now. Next slide.
Thank you, Carol. I think Dr. Cohen is next up.
Yep, thank you. Next slide, please. There are a few things to consider in the pediatric population that are a bit different from the adult population. We're doing we're using this very similar strategy for transesophageal imaging in the operating room, in the cath lab, and for other of those types of procedures. We do have to consider different PPE needs for children who can't wear masks, which are typically children under the age of 2 or 3. They just are not willing to leave masks on their face. And so in those situations, every sonographer is wearing a mask with a shield. We also screen before they come in by asking questions, and then everybody has their temperature taken and is screened at the time that they enter the building. We also have to consider the number of people in the room during the procedure. In the past, of course, families were allowed to bring as many people as they wanted to their child's visit. However, under these circumstances, we call the families ahead of time to prepare them in addition to the screening that we do on that phone call. And we ask that if it's at all possible that only one parent or guardian come with the patient to their visit. If that is not possible for the family, then we try to work out a situation such that other family members wait in the car while the child comes with only one parent or guardian. I also just want to mention, and this is mentioned in our statement, the recognition of this relatively new inflammatory disease that's been emerging in the pediatric population, particularly in children who are not necessarily COVID testing positive, but they have antibodies for COVID. So it seems like it's a post-inflammatory problem. And it's now called multi-organ inflammatory syndrome of childhood. It's a very new disease. Children present typically with fevers, with abdominal pain, sometimes gastrointestinal symptoms. So not the classic presentation of COVID, which is typically respiratory. And these patients have very high inflammatory markers, CRP and sedimentation rates, et cetera. And it can be very, very serious illness. And so we are screening many children who are presenting to us with fever and abdominal pain to the emergency department, as well as inpatient for this potential new syndrome. Next slide.
Okay, thank you, Dr. Cohen. We're going to go on to some of our questions that were submitted regarding this webinar. And so next slide, a couple of just quick questions on scenarios on tiers. So this one is regarding, patients undergoing chemotherapy. Are you scheduling these echoes as next available? In our own institution, we are considering these as tier 1 or high priority, because obviously getting the echo is getting chemotherapy and therapy is dependent on their having the echo. So these would be high priority echoes. Next slide, please. Because this one is patients are referred for transthoracic echo because of new chest pain or TIA symptoms. And the question for this is, how are you prioritizing these? Again, since we are treating new symptoms that could be cardiovascular related, and I think chest pain or loss of vision would fall in that category. So these we're getting in as soon as possible, considered urgent. Next slide, please. So this one is patients have a history of severe mitral regurgitation, and on last echo was starting to have increased LV dimensions, but they're asymptomatic. This would fall in the category of tier 2, medium priority, in which patients have known chronic cardiovascular disease, but need to be monitored fairly closely, even though they're asymptomatic. So we would consider this sort of medium priority tier 2. So next scenario is the last one too. History of atrial fibrillation, and this is a follow-up. In other words, a prior history follow-up, no symptoms. Again, this would be a routine tier 3 low priority situation. So at this point, I'm going to get to some of the questions. Dr. Cohen, there is a question for you from the chat. And the question is, oral sedation for children younger than 5. Would you consider that, or how do you do that in order to make the study potentially go more efficiently?
That is a great question, and I think a lot of pediatric laboratories are debating about that. And at present, many institutions have stopped doing sedated echoes, but it's a very good point that the echo actually goes more smoothly if we're able to do that. If institutions decide that they are going to proceed with oral sedation or any other type of sedation, it is considered an aerosolized procedure just because of the patient's airway. And so the same precautions that are used for intubation in a COVID negative patient should be used in sedating children for echocardiograms. We do recommend doing COVID testing within 24 hours prior to performing that procedure. But in general, I think many institutions are going back to do it with those precautions.
Great, thank you, Dr. Cohen. So one of the questions, another question that has come up relates to students and teaching. And I wonder, Dr. Mitchell, if you would be willing to take this question. Do you consider it safe for U.S. students to be back in the echo lab, student sonographers or students performing clinical studies, as long as they are not directly involved in COVID positive cases?
That's a great question. I think it really depends on your region and the number of cases and the amount of PPE that you have available. Certainly we all want to get students back in and get their education continuing. I think the problem that you have to balance it out, and each clinical site will be a little bit different for programs to work with. And it's going to be, is the clinical site comfortable with the students coming in? Do they have appropriate PPE for everyone? Because again, procedures have changed depending what their new normal is for what a sonographer needs to don to take care of a patient. Do they have face shields for the student if that's a practice at that institution, etc. Our schools may be going to have to look at, can they budget to help with certain types of PPE that could be kept at a clinical site for a student to use. So I think that's still a state of flux, and it's really going to be dependent for a program based on how their clinical sites are feeling about allowing students back in. And again, do they really have the resources? Part of it is too, you need to have sonographers present who are credentialed. So there's also kind of a student to staff ratio. And depending if sites are still doing furloughs, they're gonna have to be able to meet that site to student ratio as well.
Thanks, Carol, great response. I can tell you that at our own institutions, I think during, again, the acute surge, we limited student involvement and trainee involvement, but I think with the recognition that, we need to, we're gonna be living with COVID, and students still need to be trained, but we have to train the next generation. We are bringing our fellows are back and our students are back. And we're being cautious about where the training environment and where they go. But for us, we've sort of been integrating them back. Okay. This next question shown here is about screening for transthoracic versus TTE. Again, it's when do you do just a questionnaire, or are you actually doing COVID testing for them? And I wonder if Dr. Main could begin to address this, your institution.
Yeah, Judy, at our institution, we're performing COVID-19 testing within 72 hours for all transesophageal studies. So that's our standard of practice. We have 3 drive-through centers set up throughout the city. So outpatients drive through, have a nasopharyngeal swab, and have that resulted typically that same day. For transthoracic studies, for outpatients, that's simply questionnaire and temperature checks when they enter the building. Obviously, questioning of those patients at the time it's scheduled, when they arrive, and right before the study. For inpatients, it's a little bit different. We have universal inpatient testing as I suspect most others do. So everybody on admission to the hospital gets a nasopharyngeal swab, a COVID-19 test on the Roche platform. So that's how we're handling it.
Madhav, would you be able to relate how your institution is approaching this?
Yeah, thanks, Judy. This is pretty much how Mike explained it, and we're following similar precautions. And I will say this, that the level of screening, I think, is important, and at what time points that you screen. Like I said, in the operational workflow, there's for elective procedures for transthoracic echo, there's a call that's made to the patient beforehand, and then there's a call made perhaps the day before, and then when they check in. So at multiple time points, the patient is screened into in terms of whether there were any changes in symptomatology, or temperature, or any exposure to COVID-19 in the community. For example, in certain areas, such as ours, there are certain specific centers of outbreak or focal areas. So if patients are coming from some of those areas, like nursing homes, for example, where there's a known outbreak, then the level of the threshold for scrutiny is a little higher. Whereas if they're coming from a different sort of area without any kind of exposure, then testing is deferred until they meet that sort of threshold. So I agree with Mike in terms of those are the sort of thresholds and procedures we follow.
And Carol, do you have anything to add regarding screening and testing at your institution?
Sure. Ours is very similar to what's been said. For TEE patients, they undergo COVID testing 48 hours prior to the exam, and then they're asked to self-quarantine for 2 days until they come in for the exam. And then again, at entry into any facility, the patients are again screened at a station, and then also would have their temperature taken.
Okay, interesting. Okay, so could you go to the next question, Christina? Because I think this also addresses a question that I see on the chat, which is in regard to exercise stress testing and PPE. So Carol, I'm gonna again put you on the hot spot to review PPE for stress echo and exercises and dobutamine. And I think this also addresses the question on the chat.
Sure. We actually are not doing anything different for PPE between exercise and dobutamine. Our sonographers wear a mask, a face shield, and gloves. They can wear an N95 respirator if they're more comfortable with that, but that's the standard PPE that we're using for both exams.
So it's interesting. I also will say that in our institution, exercise stress echo is not considered aerosolizing based on CDC recommendations and guidelines. However, I think all of us recognize, the potential for it, especially in someone who's either coughing or breathing very hard. And although the official guidance for PPE is what you mentioned, Carol, surgical masks, some kind of eye protection, and gloves, we are deferring to sonographers if they want to use an N95 in certain situations at their discretion. So does anybody want to add anything to this?
Yeah, Judy, I just want to add one more point that, there is a lot of concern regarding stress echo and patients who are symptomatic. And, I will say that, it's about the risk of infection or the risk of transmission of disease. And that's very different between, at the very high end, you've got an aerosolizing medical procedure, such as intubation, extubation, bronchoscopy, TE, those kind of things, a procedure that generates aerosol in a symptomatic and infected COVID patient on one end, versus a patient who is an asymptomatic patient who may or may not be a carrier, who's breathing a little harder in a different setting, right? So the risk of transmission is vastly different between the two, and the levels of PPE, therefore, that would be required to prevent transmission would also need to be different. And if we are to have any sort of judicious policy of use of PPE and to conserve it for those higher risk cases where we are to prevent transmission, then it's just not feasible to consider all cases that come as being at risk for transmission of disease and N95s being required for all of them. But the data also shows that a simple, like Carol said, a simple surgical face mask with a face shield offers tremendous protection anyway especially in a patient who has passed those screening tests and is considered a low infection risk.
Thank you. The next question actually is related and to all this, and I wonder whether Mike, you could take this on. The question is specific as is basically, are you COVID testing for exercise stress echo?
We actually have followed that process to COVID test for exercise echo. Our exercise echo volume has diminished significantly over the past several months during the pandemic. I think this is in flux, and I think it's been pointed out previously, the practice patterns depend on prevalence disease in the community in which you're practicing. Our experience has been significantly different than yours, Judy. We've been fortunate to have very low prevalence of disease here in Kansas City, and we're really just reevaluating that on a weekly basis.
That's a great answer. I was going to also bring up that in our institution, we are not testing for exercise stress echo. We are testing for TE because, again, as Madhav pointed out, that you have to sort of balance the risks of the procedure and the PPE. But I think it also, it just reflects differences in practice pattern and prevalence of the disease. So I think that's an important point to bring out. So, all right. Can you go to the next question on the slide, Christina? So this is addressed to Dr. Cohen, and it's probably more common with maybe the pediatric population, but how are you handling the number of escorts for your pediatric patients? And understandably, an adult or needs to be there, but sometimes based on, the entire family will often show up for the appointment, and how are you dealing with that?
Right, so we touched upon this briefly earlier, but what we're trying to do is call families ahead of time to let them know that we are trying to maintain social distancing in the hospital. What that means is that everybody, when they arrive, as soon as they leave their car, need to put a mask on. And if they have no masks, then a security officer at the entrance of the hospital will hand them one, or hand one to all the family members. We are encouraging families to only have one adult with the patient to come to their visit for this very reason. And if that is not possible for them, there are a couple of options. We can do some of their, we can do just an isolated echo visit, and if they have to have two adults with them, we make sure that they've gone through the screening and that they have gone through the temperature taking at the entrance to the echo lab. But we encourage them, if the whole family has to come because they have childcare needs with other children, that the other family members wait in the car while the child goes through the visit and the echocardiogram. So we try to discourage more family members from coming, and if they have to come, we ask that they wait in the car if possible. And if not, we make do as best we can and try to continue to maintain social distancing other than when the patient is in the room with the sonographer.
Thank you. Those are great ideas and tips. Next question, please, Christina. So this is a question from one of our members. We had a patient with adult congenital heart disease. Sorry about the mix up in the acronyms. And whose referral was for dyspnea. So how are you handling the referrals for patients with dyspnea in a cardiology practice? Mike, do you want to take this on first?
Well, I think, we do have to follow kind of a nuanced approach here. I think the chronicity of symptoms is important here. If this is a patient who has been dyspneic for the past 6 months with no change in symptoms, no other hallmark symptoms of COVID-19, I think we would follow our usual protocols. Universal precautions, including masking of patient and sonographer. If, on the other hand, there are other red flags that this could be an infected patient, if the dyspnea is acute, then we would probably either forego the test, take red precautions, including level 3 mask or an N95 respirator, or perhaps even COVID-19 test that patient in most cases. So I think it is nuanced, and of course, not all dyspnea is the same. I think the chronicity is a real help here.
Great response. Meryl, do you have anything to add?
Not really. I agree that chronic symptoms versus new acute symptoms make all the difference in this situation. And we would take the same precautions with this patient in the adult congenital clinic as Dr. Main has laid out.
Okay, great. Sorry, great, thank you. I see a lot of questions which are coming up. You can probably hear the medvac coming over my hospital right now. I will just comment that a lot of the questions on the chat are in regards to stress echo, aerosolizing, and testing. I believe we've addressed that during the multiple comments already. So I will move on to this question, and it's addressed to Dr. Madhav. Can you comment on the recent Lancet article that concluded that N95 masks offered better protection than surgical masks for risk of infections for healthcare workers, and what that might mean for future PPE use?
Yeah, thanks, Judy, for that easy question that you reserved for me. But yeah, so this was an interesting study that was released just earlier this week by Lancet, and it included a meta-analysis of several studies that were pulled together from specific WHO data sources. And this went back all the way to SARS and the Middle Eastern Respiratory Syndrome, the MERS, and then the current SARS-CoV-2 or COVID. And so they pulled together about several studies and came down to about 44 studies, which they did a meta-analysis on to look at levels of protection and social distancing norms and the transmission risk. And one of the things that they concluded in this was that N95 N95 respirators and similar design respirators offer better protection from transmission of disease than surgical masks, which offer more protection than cloth face masks, for example. And so this is not a dramatically sort of new finding, but one of the factors that was picked up in this article was that it would be better for policymakers to suggest N95s for all healthcare workers as opposed to surgical masks, given the lower risk of transmission with N95s. On delving down into this article, actually, there were several points that the authors made. Well, first of all, that the N95 versus other mask comparisons were feasible only from 4 studies, out of which 2 were from SARS outbreak in China, 1 was from the MERS outbreak in Saudi Arabia, and 1 was from the COVID outbreak in China as well. And so looking at, the combination of these studies, yes, N95s offered greater protection, but they had a hard time controlling for other factors. So they concluded that this result, this analysis was, of low certainty, that there was actually that much better protection to make confident conclusions regarding it. But either way, what they also found was that distancing was good and the use of face shields was really good. And so that offered an extra level or barrier, which supplemented certain other protective equipment as well. So N95s, yes, they do offer better protection, but they also cautioned against universal adoption, because the level of transmission was not corrected for in terms of the setting in which these masks were used. For example, in a negative pressure room versus a positive pressure room versus a setting where the transmission was higher or lower, the number of people involved with the distancing involved, none of these were corrected for. So they cautioned against interpreting this in too concrete terms. But it remains to be seen how we as healthcare leaders or providers, are judicious in our approach of how and when to use the right PPE in the appropriate conditions.
Thank you. Thank you. I'm going to take a question now from the chat. And the question is, COVID-19 is predicted to be around for at least a couple of years, if not longer. Do you feel tiers of priority will be there to stay that long, or the foreseeable future. And I can address this. The point of developing a priority tier was really to provide guidance on the rescheduling of the backlog that invariably, at least a lot of the institutions had, due to just us shutting down our outpatient volume during acute surges. It was really that was sort of the patient population that was specifically addressed to. I think, but also I think these tiers are used, in a clinical sense already, in how we prioritize urgency of echoes, and we just try to just codify it in a graph for folks for guidance. So, taking another question, just specifically, one of the questions is: are you currently classifying treadmill stress echo as an aerosol generating procedure and requiring COVID swabs prior to testing? I think that the issue is, I just want to make, if there's a distinction between quote exercise echo versus treadmill echo for folks. I didn't know if Carol, if you want to take this on, or.
I can defer to you, Judy, that's fine.
Yeah, no, that's fine. I mean, I just want to make the distinction that when we say exercise stress echo, we consider that to be both treadmill or supine bike, which is the two common types of exercise echo. I'm not aware of any studies distinguishing whether one is more aerosol generating or not. And again, in terms of COVID testing, at least in our institution, we are not testing for COVID for stress exercise echo. Okay, so if you could go to the next question slide, Christina. This was a question basically to get some more clarification on this new syndrome of PMIS, which I have to ask Meryl, I don't know who came up with that one, the acronym, but.
It's actually now it's MISC, because that seemed really.
Yeah, PMIS, there's a lot of issues with that. So thank you. It's now MISE.
It's multi-system inflammatory syndrome of childhood.
I love it. Okay, so mice. Good.
Yeah.
Okay.
Or miscellaneous,
yes.
You could say,
Yes,
perhaps.
yeah. And I think the question is, what should we be looking for in particular in regard to the echo findings? Are they seeing, are you looking for the coronary aneurysms that's akin to the Kawasaki?
Yeah, this is a great question. So we're really learning literally every day about what this new syndrome is all about. And we've been sort of collaborating with our colleagues in Asian countries and then in Europe, because they saw the wave of this disease before we did. What we've learned so far is that it presents in a very similar way to Kawasaki disease. And for those of you who are not in pediatrics, Kawasaki disease is an inflammatory disease of unknown etiology, where the patient has pan-inflammation, very high inflammatory markers, and can unfortunately have inflammation of the coronary arteries, which can lead to coronary artery aneurysms. And so we've learned that there have been some rare cases of what we think is this MISC disorder, where we've seen some coronary aneurysms. The issue is that we don't know if those patients actually have Kawasaki disease or if they have this new syndrome, because they're testing positive for the antibody for COVID. And so it's very hard for us to know what's what here, and which came first, the chicken or the egg. So what we do look for in patients who we are suspicious of having this disorder is we look to make sure that they don't have myocardial inflammation, so signs of myocarditis such as ventricular dysfunction, new AV valve regurgitation. We look for pericardial and pleural effusions, just again as part of a pan-inflammation assessment. And we do target the coronary arteries to see if we see any dilation or aneurysms. We have had a couple of cases at my own institution of mild dilation of the coronary arteries, which we've seen in patients who we think have this disorder. We have not seen overt giant coronary aneurysms here, but there have been some case reports, particularly out of Europe and the UK, where they have seen some coronary aneurysms in association with this disorder. So one of the most important take-home points is if you are suspicious of that a patient may have this MIS-C, then they should probably have a screening echocardiogram. Obviously, they're going to go through the testing. And then if you're really highly suspicious, if their inflammatory markers are very high, then they need to have serial echocardiograms over the course of their illness to assure that you don't see changes such as the development of coronary dilation or aneurysms.
Thank you, Meryl. That was great. That was great. This next question, if I could address to you, Madhav, since I'm giving you all the hard ones, just wanted to preempt that. So the question is, with so many nationwide protests currently, many subjects may be exposed to COVID-19. If any of them need an echo, what do you recommend?
Thanks, Judy. So it's an interesting question, and with seeing all these nationwide protests and these gatherings that we see on the television frequently, a lot of people are seen wearing some masks and some are not seen wearing masks. But the concern obviously is that what is the impact of this on the spread? And the CDC came out with a statement, I think today or perhaps yesterday, saying that people who were involved in these demonstrations should go for voluntary COVID testing, because this does look like a seeding event in a lot of cases. Now, it may be different depending upon where some of these protests have been staged in smaller areas where the pandemic is at a different stage versus, let's say, the middle of New York City or Los Angeles or some other places where the pandemic is still, the risk of transmission is very high in the community. So depending on where they are and what kind of risk area they come from, it may be beneficial to get COVID testing. Now, if some of them do need an echo, we should probably follow the same protocols and tiers in terms of the prioritization as to where they're coming from. And perhaps at the screening level, one of the additional questions would be that, have you been exposed to a COVID exposure, high-risk COVID exposure situation? And one of those situations could be like a group protest where you have been in close proximity to a number of people in the community, which was not controlled, such as, for example, if you go to a grocery store or some other kind of area, there are usually social distancing protocols in place in many of those places. But in a group setting, like the uncontrolled setting like a protest, perhaps that may not be. And that could be added to a screening questionnaire and extra precautions taken for those patients who haven't tested yet.
That's a great idea. Thanks. So these next two questions are displayed, and I'm going to address them specifically to you, Mike. What situations should we be using limited or focused echoes during the COVID pandemic?
Well, I think one of the issues on the outpatient side is we've got this incredible backlog of deferred tests. So we need to look for opportunities to increase laboratory throughput while maintaining quality. And within our lab director, David Skolnick, put a lot of time and effort into devising 6 new protocols, focused protocols. These are all in the follow-up setting. So patients with aortic stenosis, mitral regurgitation, ascending aortic aneurysms, pericardial effusion, pulmonary hypertension, and then those patients in whom we are simply wanting a reevaluation of LV systolic function. For instance, if we're trying to determine candidacy for an ICD for primary prevention, for instance. So I think those are some concrete examples of where we can use limited or focused echoes during the COVID pandemic. On the inpatient side, I think in a COVID positive patient, we want to answer the clinical question. We want to try to limit exposure on the side of the sonographer and other healthcare workers. So I think careful consultation with the referring physician, what is the clinical question that we're trying to address, getting in there and answering that question, maintaining quality, but making sure that we don't needlessly expose healthcare workers to COVID-19.
Sorry. And this next question, Christina, is also directed to Mike. What about the use of ultrasound enhancing agents during COVID-19? Should we be treating them any differently?
I don't think we should be treating them any differently at all. Our lab adheres to the ASE guidelines on the use of ultrasonic contrast agents. We have historically used contrast agents in about 30% of inpatients and about 30% of outpatients. So a fairly high utilization if you look at that in comparison to what is being done nationally. I think we should continue that. There's no reason to change. They've provided value pre-COVID. They certainly continue to do so now. I think one thing to keep in mind is that the UAEs have shown excellent safety profile amongst even the sickest patients, and they've been well studied in patients with pulmonary hypertension and underlying lung disease. So we shouldn't let a COVID infection dissuade us from use of contrast agents.
That's a great point. Thank you, Mike. If you could go to the next question up. And I think this question is somewhat broad, but it also addresses questions that are coming up in the chat about procedural, time in between patients and all that. So I just read the question. How are you scheduling patients for echoes? Are you giving more time for check-in? And then the fact that you have to do PPE and the extra cleaning between patients, how is your scheduling regimen potentially changed? Mike, do you want to address this first?
Well, I think early in the ramp-up period, it's important to allow extra time to make sure that the additional protocols that you've put in place can be achieved in the time period that you've allowed. We have now reverted to our previously scheduled time for echocardiograms, 55 minutes per study. And one change we have made, however, is that inpatients are all now done at the bedside. In the past, and we hopefully in the future, we've typically brought these patients down to the lab in every case possible. Now we're studying those patients in their rooms, and that decreases traffic throughout the hospital, the chance that you're going to bring a COVID positive patient in contact with other patients. And in the lab, in terms of outpatients, we're using direct rooming. So they come in, there's somebody at the front desk, they're directed to the exam room. Registration is done with a computer on wheels at the point of service. So those are a few of the steps that we've taken.
Oh, those are great ideas. Those are great ideas. Meryl, do you want to describe of whether things have changed for?
Sure. I think we've taken on a similar, similar pattern as Dr. Main was talking about. We're not quite up to full speed yet. We've tried to limit the number of patients that come through our outpatient facility. So we have now a greeter who screens all the patients as they arrive in the waiting room. We try to limit the amount of time that they're spent there, and all of the areas where they can sit are socially distanced and then scrubbed down after every family leaves. The family is registered and then put into an examination room. Then the sonographer comes and gets the family and the patient in PPE, brings them to the echo room, completes the study, and brings them back to the exact same exam room. And then after that is done, all of the rooms are cleaned appropriately. We've extended our time to enable this to happen safely. We've always done our inpatients at the bedside, so that didn't really have to change for us. But we've extended the time in order to be able to clean down the rooms and the bathrooms in between patient experiences.
So you have allowed a little extra time, at least initially, as we ramp up. So we've done actually the same in our own institution. And we're, as I said, I think these things are fluid. Carol, do you want to discuss what your routine has been?
So we, again, are actually back to our normal procedure times with no COVID blocks. Patients are told to come a little earlier for the screening process at the entry into the building. Again, we've kind of gone to a new standard cleaning where we're, wiping everything down after every patient, including the door hooks and handles and any hard surface that a patient or sonographer may have touched. So that's what we're doing. But again, we're back to our normal procedure times.
Can I make one more comment, Judy? Sorry. We often have had patients who come way too early for their appointments. And that means that they have a much longer waiting time. And so what we've told them is that if they come way too early for their appointment, they should expect that their appointment is on time and that they're going to have to wait in their car until the time that they're supposed to register. Because it used to be that we would either try to take them early or, sort of make way for them or send them down to the cafeteria or something. But we're really asking them to really be, 15 minutes before their visit rather than an hour or an hour and a half before.
Right, the waiting in the car, I've heard being used, and then texting as well. So, but it's important to make sure the social distancing is in there as well. I'm going to address the next question that I see on the chat. So the question is, if a patient was COVID confirmed and hospitalized, and then the TTE at that time was deferred as an inpatient because it could be they were COVID positive. And now the patient, we need the echo scheduled as an outpatient. How do you handle COVID recovering patients? Is there a certain time frame we should wait to schedule? Well, this is obviously a scenario that's come up a lot for all of us, and we are deferring to infection control at our institution, which has instituted fairly strict guidelines on COVID status and when they can come in for an outpatient test. So at least in our own institution, they have to wait at least 2 weeks before they can come in for testing. And all our patients actually are flagged with a COVID status. So if we see that they have a COVID status, we know that we cannot schedule them. We cannot schedule them until after, when that COVID status flag is removed. And that typically is, again, 2 weeks after the COVID positivity. In situations where patients have been COVID flagged, either risk or, recent infection, but they need that echocardiogram, we actually have a special clinic that only accommodates patients who are in this risk category. So they all go there, and we will do the echoes in this specialized clinic. I don't know if anybody else on the panel has similar tips or ideas on how you've been handling these situations. Okay, so let's then go to the next question. I think we're really good. Oh, well, isn't that interesting? We just did that. And I had Mike, but I don't know if you can certainly defer, or since I basically just answered the question. So
I think that was a great answer, Judy. Nothing really to add there.
That's very good, especially to the incoming president-elect. Excellent answer. So next, okay, this is a question regarding stress echo. Obviously, a lot of questions regarding stress echo. For stress echo, are you converting to pharmacologic stress? Are you considering physical barriers between the patient and sonographer? And for the first part of that question, perhaps I could I could ask Mike to address that, just the first part, and then maybe Carol, the second part.
Yeah, we're trying to do the test that the physician has ordered. There's obviously many instances in which physical stress is superior to pharmacologic stress. So we're trying to do that. We do know in the nuclear world that there has been a push to forego essentially all exercise studies if possible and switch those to pharm stress, PET if possible. But that has been our practice pattern. In terms of physical barriers, we have not implemented anything in that regard.
Carol, I don't know if you have any comments on that.
Sure. Again, we are using, sonographers wear a mask, a face shield, and gloves for performing the stress echo. And we are not using any physical barriers between the sonographer and the patient. I think there have been on the website, on our ASE website, several labs that have shared ideas for how to use kind of a barrier using cardiac cath covers and things like that. But I think you would have to balance it out depending on your room for safety of the patient and be able to getting them from a treadmill to the bed and in the time you needed may be difficult. If you're doing a pharmaceutical stress and that's something that your institution might support, you certainly could consider a barrier. And there are some designs and examples that we have on our ASE website and resources. Our institution is not using physical barriers.
I can comment on this too. So it's been a sort of a mixed reaction, I guess, among our sonographers regarding the use of physical barriers. Some have said that it sort of impedes the scanning for them, for some, and some not so much. But I would say that we have provided the plastic sheeting and the sort of IV pole setup. And again, it's sort of in deference or deferring to the particular sonographer if they want to use it. So, all right. So actually there's a next question. Next question is, how have you adjusted the workspace for the reading room doctors and sonographers? Is there a minimum distance between workstations, maximum number of people per room, limiting number of people accessing each workstation, you know, and communications between doctors and sonographers remotely? This is a great question. I'm going to start, and I would please have the panelists pitch in, because I think we've all had to deal with this. You know, our inpatient reading room is about 6 feet by 10 feet. So we clearly have had to, you know, the interaction between doctors and sonographers are now done either remotely, communicating via email or text or phone call. Obviously the problem for a lot of us has been the teaching and the reading that we always used to do together. And, you know, teaching is a very part of our mission. So we've actually gone to Zoom reading. And that actually works okay, believe it or not, because you can share the screen and you can share the reading. And it's actually worked okay. We're hoping that we're looking at ways to sort of divide the space up so that we can have at least 2 or 3 readers in the physical room. But right now we've been doing Zoom. So, and I don't know if anybody has comments on how they've dealt with the physical distancing necessary during the workspace.
I can add a little bit too, Judy. You need to come to Penn to have a bigger echo reading room, I think. So we have a fairly decent sized room. What we generally have 4 to 5 readers a day. So what we've done is we've had at least one person who's in the room so that the sonographers can come physically distant to sort of talk to that person who's running the lab during the day. We usually have a second person in the room at the same time, socially distant. If you can't be distant, everyone wears masks. And then obviously everybody wipes down their spaces appropriately before the day begins and at the end of the day, and nobody sits in each other's spaces. As far as teaching goes, we have implemented blue jeans to do our teaching of cases in the mornings with the cardiology fellows and students, and that works relatively well. They can all pull up the study at the same time that we are and go through it together. The sonographers can either call us or they can come into the room physically distant to talk to us, but we still wanted to have that engagement. And the Echo Lab used to be sort of the hub of where everybody came to discuss things, and that has gone away, of course, because we don't want other people walking into the room. So now anybody who has a question about an echo, we ask that they call rather than come into the room.
Yeah. Any other hints or tips on what people are doing to? Those are great ideas. I think the main message on that is that we certainly have had to be better about communicating, because before it was easy, you just walked in and you know, but now it's you know, being proactive, making sure you touch base with the sort of our sonographers on the studies and all that. It takes a lot of extra work, but it's important to do so that we're all on the same page on that. So that's been a lesson for us. And I exaggerated. So our room is actually 8 by 10. Sorry, not 6 by 10. So we could fit 2 people. That's about it. All right. So I actually don't see any new questions. A lot of, again, the questions are on PPE and treadmill and exercise testing, which we've done already, we've reviewed already. And so I think given the time, and I will probably conclude and thank everyone for their participation and thank my panelists for their discussion. And so I will end the meeting. And I want to thank everyone for participating. Really great questions and discussion.